Rare inflammatory conditions of the renal pelvis. The following conditions may all occur in the pelvis, the ureter, or the urinary bladder, though they are likely to be chiefly or even exclusively confined to one or the other extremity of the urinary reservoir. All of them are rare. All of them appear to have some relation to chronic bacterial infection and inflammation of the pelvis and bladder. Pileitis granulosa. Pileitis granulosa or follicularis is a lymphoid infiltration of the mucous membrane of the kidney pelvis. It is apparently the result of chronic piolitis, though it is said to have been found post-mortem in uninfected cases. The pelvis presents a rough and pebbled gross appearance. The microscope reveals little aggregations of lymphoid tissue in the mucosa. They are vascular and show a tendency to capsule formation. The larger ones may ulcerate. They usually produce no symptoms. They may bleed or deliver pus. Leukoplakia. This consists in grayish or yellowish nodules made up of large cells, 20 micrometers in diameter, containing colon bacilli, leukocytes, and peculiar cell inclusions. These nodules may be found in the renal parenchyma as well as on the mucous membrane of the urinary reservoir. Pileitis cystica. This condition, like the preceding two, is usually associated with chronic inflammation. It is commoner in the bladder than in the pelvis of the kidney. The lesions are usually multiple and vary from small red elevations on the mucous membrane that look precisely like piolitis granulosa to larger bodies that, when seen through the cystoscope in the bladder, for instance, or observed in the kidney pelvis post-mortem, look distinctly cystic. The cysts apparently never attain a very great size. Under the microscope, the lesion looks very much like a papilloma, with the difference that the true neoplasm springs from the surface of the mucous membrane and projects above it, while cystitis cystica is, as it were, inverted and digs under the epithelial surface of the mucosa. The larger lesions are frankly cystic, figures 68 and 108. Leukoplakia. Leukoplakia occurs much more rarely in the bladder than on the tongue, much more rarely in the kidney pelvis than in the bladder. No relation has been established between urinary leukoplakia and syphilis. Published reports do not suggest any tendency to malignancy, although leukoplakia of the urethra is a distinctly malignant condition. I have seen 2 cases of leukoplakia in the bladder, the lesions occupying the fundus, and the regions back of the ureter mouth. I have never seen leukoplakia of the kidney pelvis. The bladder lesions resemble those seen upon the tongue, a whitish, thick, epithelial flat surface with a reddish border, while here and there in the vicinity are seen reddish lesions of chronic inflammation upon which the squamous epithelium has not yet collected in sufficient quantities to give them the white color. Calculus incrustations. Phosphatic incrustation upon an ulcerative inflammatory lesion is always due to ammoniogenic bacteria, usually the pyogenic cocci or the proteus. Phosphatic incrustations are also seen on the renal lesions of tuberculosis. Indeed, this is the commonest form of incrustation in the kidney pelvis. Bladder incrustation is usually the result of the infection following upon the establishment of a permanent suprapubic fistula, but it also occurs in connection with phosphatic stone, tumor, and even in cases of chronic piolitis and cystitis. Incrustation and ulcer alike are the expressions of the reaction of the mucosa to a virulent ammoniogenic inflammation.